Hello, this is the NICU Lived Network, and we are your hosts. I'm Melinda.
I'm Nat.
And I'm Emma. We are all NICU mothers using our lived experience to partner with health professionals to impact research, advocacy, and clinical practice.
Each week we will bring you something new. It could be a topic highlight, the latest in research, a visit to a NICU, or ways in which you can use your lived experience within the NICU to impact change. We hope you enjoy this episode.
Well, hello and welcome to another episode of the NICU Live Network. You are with Mel and Nat. Hi, Nat.
Oh.
Em's unfortunately unable to join us today, but we have a really special guest, and you may remember him from our live on International Clinical Trials Day, but we are joined by Associate Professor Brett Manley. Hi, Brett.
Hey, everyone. Hey, Mel. Hey, Nat. Great to be here again.
So good to have you. So for those who don't know who Brett is, he's a neonatologist at the Royal Women's Hospital in Melbourne and also Associate Professor at the University of Melbourne. And he conducts multi-centre clinical trials that help improve the lives of and outcomes of babies that are born premature and sick. So today we are talking about Brett's top 5 recent papers in neonatology. So it's really exciting for us to learn what's out there, particularly as parents. And I guess the purpose of the podcast and doing this is talking about research and advocacy and how parents can be more involved. So thank you for joining us.
Oh, it's great to be here. Yeah, this is exciting. I quite, it's exciting for me as well to go over some of those really important studies that have come out recently and help get the message out there. And yeah, hopefully this is something we can do from time to time, and I can keep everybody updated on some of the big results.
Yeah, absolutely. So you've got some slides and we can dive right in, but just quickly, how did you pick these top 5?
Well, these are 5 studies from the last couple of years. They're mainly within the last year or 18 months where I feel that they've either really changed clinical practice or have the potential to change clinical practice and improve outcomes for preterm and sick babies, and or they've really struck a chord with the community. And you'll see why with a few of them. Some of them are just fantastic studies. And I think it's really important that when there are big studies, they take an awfully long time to do. It's really hard to do. And it's really important to get the message out once we've got some really good results.
Yep, that's great. Okay, so should I bring the slides up?
Yes, please.
Let's go.
All right. Well, thanks again for having me, Mel and Nat. So I've got a bit of a theme for today's 5 studies that I'm going to talk about, and that is less is more. And I think when you think about neonatal intensive care in countries like Australia and other Western rich countries, we tend to be doing more and more, that we're looking after babies that are smaller and smaller. Here's a little 25-weeker who's a couple of seconds old, but we're looking after babies almost half this size now. Babies born at 23 weeks and 22 weeks. That involves a lot of technology, a lot of intensive care and a lot of intervention. But there's been some really important messages over the last few years to tell us just to hold up a little bit and actually try and be mindful of not always doing everything. A great example of that is delayed cord clamping. And you guys are aware of this story, but the story that we've had for decades and decades now of us all clamping the umbilical cord straight after babies are born. And we now know that that's simply the wrong thing to do, that in fact we should be waiting for at least a minute before delaying the cord whenever possible. Now, it's not always possible. You might have a really sick baby that we need to jump in and resuscitate, but most of the time this is something that we can easily do. And even for very preterm infants that are born a couple of months early, a big Australian study called the APTS study showed that, in fact, if we wait a minute to clamp the umbilical cord, mortality, death, is reduced. I mean, you can't have a more important outcome than that. So now this is something that everybody's trying to do, and this is just to kick off the theme and get us in the mood for the studies that are to follow. I point out here as well that even the tiniest babies and sick babies, we're now trying to delay their cord clamping, and there's studies going on around the world using these sorts of bedside resuscitation areas where you can move them right up to the mum who's giving birth or right up to the bed during a cesarean section. and we're trying to work out whether babies can be placed on this even in the first seconds or minutes after life and receive everything they need still attached to the umbilical cord. So that's a watch this space for that one.
Okay. So, Brett, can I just jump in? The umbilical cord, the waiting for a minute. Why does it? What is so good about it? Why does it lower mortality exactly?
Well, so it probably depends on which group of babies we're talking about. But in the bigger babies, at minimum, what it does is allow more blood to be transfused across to the newborn baby from the mother. So if you cut the cord, that immediately separates the blood supply, the placenta, from the baby. And if you leave it open, there's more blood that can go across. And that's probably good to have a higher blood level or a higher hemoglobin level after birth, avoiding the need for things like blood transfusions. In little babies, where we worry more about things like fluctuating blood pressure or the circulation changing too quickly from being inside the mum to outside the mum and leading to bleeding in the brain and those sorts of complications of being really small and preterm, we think that keeping the cord attached or delaying the clamping of the cord just allows that circulation change to be a bit smoother and a bit gentler and avoid some of those really big fluctuations in things like blood pressure that might lead to bleeding in the brain. So that's probably how it all works. Wow. But it's really amazing, isn't it? Just that simple thing can have a big impact.
Where did that kind of come from? And like, I've never had the experience of not having a baby not go to NICU, so I don't know what happens when a baby's born full term, and it's a much different experience because dad gets to cut the cord, and I don't know how long the delay is. But I know, like, in the past, like speaking to people like my grandmother's age, and that, like, the cord would be left sometimes until the placenta was delivered. I had a friend who had a few years ago a home water birth, and I asked her husband how long before the cord was clamped, and he said about 8 minutes. So traditionally it seems to be a thing that you would leave that. Why in the neonatal space did it become a thing to cut it so quickly? Like, what?
Such a good question, Melinda. I'm not sure anyone can answer it definitely. There's always been people who've, mums and families and dads that have asked to delay the cord clamping, and told us don't clamp it unless you have to. And so that's been ongoing. But there was just this sort of practice creep across decades where any time that there was an emergency or doctors were attending a birth, it was felt that, oh, well, then we need to clamp the cord quickly and have them assessed or have them stabilised or have them resuscitated. But as time has gone by, firstly, doctors have learnt that we don't always need to jump in and resuscitate babies. Most of them will breathe on their own and you need to give them a bit of time. So that sort of urgency has slightly diminished. And secondly, we've just realised that we were doing the wrong thing. And so how we ended up there is a bit of a mystery, to be honest. It's sort of the medicalisation of the birth process, which in many cases is required. Okay, we might get into a big argument here, but certainly, baby in hospital is a safe place to be, and there are many mothers that have to have their babies in hospital for various reasons. So that's required. But even in those emergency type situations, if the baby's breathing and looks okay, leave it on the cord. And to answer your first part of your question, that can be for many, many minutes. I mean, there's almost no limit. And as you say, in some cases, that's left there till the placenta separates even. But for many minutes is the answer.
It's amazing, isn't it? And such a big difference. You said 8 to 11%.
Yeah, it might not seem like that big a difference, but I can tell you it's rare to find a difference in mortality or death in the studies that we do. They've got to be really big and really well performed, and that study was to demonstrate that few percent reduction, which is, in such an important outcome, we'd take that every time.
Yeah.
Hey, we weren't even going to talk about delayed cord clamping. That was the introduction, but such an important concept. And I know, Melinda, you're involved heavily in some projects looking at trying to make sure we implement delayed cord clamping very consistently around Australia. Yeah.
And part of that is educating parents too, so that when they are in delivery or when, they have that discussion about what their birth plan is, that they're asking for it as well, because they've got some education and awareness on why it's so important.
And even for extremely preterm babies, we're trying now, even if a baby's born at 25, 26, really, really low gestations, if the little prem baby breathes and looks okay straight after birth, we will try our hardest to keep the cord attached for at least a minute before we move the baby. Yeah, really important.
It's partnering with Mother Nature, isn't it? So still need the intervention, still need the medical support, but work with Mother Nature and how she can help as well.
Yeah, we're getting better and better at it, but we've got a way to go. And as I say, that's part of the project that you're working on to make sure we're all doing a good job. So that's great.
Absolutely.
All right. So speaking about separation, we were talking about separation from the cord. It's pretty related, though. I want to talk about this amazing study called the Kangaroo Mother Care Study, which is trying to achieve less separation of the mother and the baby. So this is quite a famous study. And yes, if you're wondering where the term kangaroo care or kangaroo mother care comes from, this is Australia at the forefront here. It comes from the fact that, kangaroos will keep their joey in the pouch and stay together. So this study got a lot of media and got a lot of attention and reached as far as the front cover of the National Geographic, which talked about the power of touch, which I'm sure for a lot of mums and dads out there who've had preterm or sick babies, that phrase, the power of touch, is something that probably really strikes a chord. So this study is just incredible. This was performed in 4 or 5 African countries and in India. And the concept here was they basically, in most of those countries, that the standard practice has been any time a low birth weight baby is born. So we're talking sort of the babies between 1 and 2 kilos, not the tiniest babies that we look after in places like the intensive care unit that I work, not all the way down at those gestations. But in Africa and India and low and middle income countries, many of those really tiny babies still can't survive, but it's these ones that we would expect always to survive and never to have major problems who still have a lot of mortality and morbidity. So this study, basically, they divided their neonatal units into 2 halves, and in some cases they even built a new neonatal unit to allow this to occur. Half the mothers were treated in a standard way. That is, that if their little preterm baby was born, they might have a cuddle or they might not, but the baby would be whisked off to the intensive care unit pretty quickly. And in the intervention arm, where they were trying to keep mothers and babies together, they tried to do exactly that, put the baby on the mother, and if the mother was somehow unavailable, they would even use a family member to do this, and try and keep the baby on the mother for as much of the day and for as long as they could, which probably made the doctors and the nurses stop touching the baby a little bit as well. So what happened? Just that simple intervention. Well, this is what happened. They had over 3,000 mothers and babies, which is firstly amazing. It's a really big trial. They were 1 to 1.8 kilos. So they are very small babies, but not the tiniest babies. Nat?
Oh, no, just teeny tiny babies.
Oh, yeah, that's right. And so you can see they achieved what they were trying to do. In the kangaroo mother care group, they had skin to skin on average for 17 hours a day, compared to only 1 or 2 hours a day in the standard care group. And look at this. They reduced death by 4%, from 16% to 12%. And the babies had less low temperatures and less suspected infection than just by being on their mum than the babies that weren't. That's incredible. This simple intervention, which sort of seems obvious, doesn't it? Keep the mother and the baby together. But by really trying hard to do that, they reduced mortality. It's just amazing.
Well, we know this with FICare, like how important it is to have mums or parents' involvement and how important the skin-to-skin is. But looking at it straight away from delivery, I think that's just incredible. And
there are lots of benefits.
Can you just go back to that slide? Because I'm just thinking, so Elijah was 34 weeks and he was just on 2 kilos. And like, I'm interested if there was any outcomes in terms of how it helped the parents or the mum emotionally, because as soon as he was born, for me, one of the first things I kept calling out was, is he okay? Is he okay? Is he okay? And I remember the doctor saying to me, if you be quiet, you hear that he's crying. But I couldn't, because I like that was my thing. And then he was gone. So then I had this big break because I'd had an epidural. I was stuck on the bed. Like I couldn't, like there was this gap before I could go back and see him, even though he was 34 weeks. So this would have changed my life if he could have been well enough to stay with me. And then even with Dylan being born at 27 weeks, he was just on 1 kilo. So this could have been something appropriate for me to stay with him as well.
Well, possibly. So it's important to recognise that this study was done, as I say, in low and middle income countries. Where there's less sort of intensive care equipment or even ability. So I'm not suggesting that if we did this necessarily in Melbourne, Australia, that you might get this big an effect on mortality, because we would expect all of these babies to do really well. Whereas
I'm just thinking more about how.
No doubt. Now, I don't think they've published anything about the mothers or asked them anything yet, to be honest. But I think I know what answer we'd get from you, Melinda, and from you, Nat. And absolutely. And this is something that, again, we need to be better at. So in our neonatal units around Australia and New Zealand, for example, we try very hard to encourage a lot of skin-to-skin care through the day and through the hospital stay of preterm babies as they're growing and improving. And we know that's good for their neurodevelopmental outcomes. We know it's good for things like establishing breastfeeding. There's no doubt about that. And we know that when babies are on their mothers, often their temperature's really well controlled and their heart rate seems to be well controlled. They seem to enjoy it. So we certainly try very hard, but this concept of straight from birth is something we don't do very much in Australia. I think I was chatting earlier, Melinda, and saying that in Scandinavia and places like that, they're getting much better at this, even in really tiny babies, even extremely preterm babies like 27 weeks, where the babies and the mothers stay together throughout. Still in Australia, we're not that good at it.
I just think it'd be nice because, like Melinda, like I had twins, and it just like you hear about people being able to hold their baby afterwards, and I just go, oh, that would have been nice. Like I think I saw the head of one, and then that was it. It was kind of like, oh, I think I had kids. Like it just kind of left in the operating room.
And
but, you know,
there are reasons.
The experience.
There are some mothers and babies where this can't happen, and because babies are too sick or mum's too sick. But I think that's not really what we're talking about. We're trying to say, in general, we should be trying to do more of this, more delayed cord clamping and more of keeping mothers and babies together. And of course, in a country like Australia, I mean, it's not all about the doctors and nurses. You know, families are busy. Families have got other kids at home. They've got jobs. They've got parents to look after. They need to come and go from the hospital. And so it's not so simple just to say, oh, everybody just do 17 hours of kangaroo care a day. Isn't it? We can at least do better than we are.
Yeah. So does that mean if babies need lines put in or when they're tubed, it all happens while they're on mum?
Well, theoretically, that could happen. I think some of those things are tricky, like putting lines in's got to be sterile. So, again, I'm not sure much of that sort of stuff was happening in the study I presented, but, you know, could we do this in sicker babies that needs that sort of thing is an outstanding question. Yeah. All right, I'm going to change tack a little bit, if that's all right.
I just love how, like, the thought of, you know, keeping mum and babies together is a focus. Like, it's amazing.
Yeah, absolutely. Critically important. All right, I'm going to talk about another less is more topic, and this is about platelet transfusions. Now, platelets are not a particularly exciting blood cell, and probably not one that many of us are that familiar with. You've probably might have heard about hemoglobin or red blood cells, which are really important to make sure that they're topped up and working well and carrying oxygen around the body, and that's why a lot of babies or preterm babies need blood transfusions. But these are specific cells called platelets. They're small little cells that are involved in clotting. And what we find is that particularly in sick babies, in very preterm babies, and in babies that are small for gestational age, so these are the babies that weren't growing very well, they are often classed as being called growth restricted, having fetal growth restriction or in utero growth restriction. We call them small for gestational age when they're born. And those babies who are smaller than expected often have issues with their platelet levels being low. So it's not uncommon for us to need to transfuse, or for us I was about to say to need to, but maybe we don't always need to, for us to transfuse platelets when they reach some arbitrary number. And you don't need to know all the science behind it, but for some people that's 100, for some people that's 50, and we've really not known what we should be doing. And this amazing trial that came out of the UK by this group of researchers here compared whether we should transfuse platelets when they get to 50, which is what most people were doing, or leave it and wait until they got to less than 25, which is a level that I think a lot of people before this study would have been a little bit worried about, because if platelets go too low, you get really worried that there's going to be bleeding, and particularly in preterm babies, you get really worried about bleeding in the brain. So for most of us, we would probably have transfused babies that were getting to 50 or below, and in some cases even 100 or below. So this was, pretty out there trial, really pushing the limits and saying, well, hang on, could we wait a little bit longer in these babies? And why this is so amazing is that these were over 600 babies born 34 weeks. They had a mean gestation of 27. That means on average they were 27 weekers and pretty small babies. If they waited until the platelets fell to below 25, as expected, they had to transfuse less often. That's expected. If you're transfusing at a higher level, then you'll give more transfusions. If you wait longer, then you'll give less. Half as many platelet transfusions. But look at this main result. Waiting until the platelets dropped below 25 to give a transfusion did not increase the risk of bleeding. It decreased the risk of bleeding. So babies had less major bleeding episodes, that they define what that is in the study, and less death by giving less platelet transfusions. So this is exactly the opposite of what you might have thought before we studied. You might have thought, gee, they're pushing the limits. You wait until it's less than 25 to get those platelet levels back up, be really worried about bleeding. That's not the case. Waiting, as long as there's no major complications, is a good thing. So this is about less is more. Less transfusions is probably a good thing. Now, the big question is why? And to be honest, you were about to ask, to be honest, we don't know.
Why? Why did it happen? Yeah.
But presumably giving transfusions, which come from other human beings, giving transfusions of cells like this causes inflammation or some reaction in the body that maybe leads to more inflammation or problems later on. It's not exactly clear. But what it tells us is, again, do less. What do you think about that one?
It's great news. Will they potentially do that study elsewhere? Because that's a UK-based study. Will they do it in other countries as well?
I don't know if they're planning to. This is a fairly definitive result. So I think most of us, even over here in Australia, would look at it and say, well, the centres that they did it in, we can relate to. They're very similar to ours. The babies are the sorts of babies we care about and not care about, but, the sorts of babies who might have a platelet transfusion. And so I think most of the world is convinced, to be honest. And we immediately changed our practice in Melbourne.
Oh, really?
Yeah.
That's great.
So now on my ward, I remind everyone, I say wait until the platelets are less than 25 unless there's another reason. Yeah.
And how low under 25 could it go?
Anything under 25. So, we can't comment on anything less than that. We can't say, well, can you wait till it's 0 or can you wait till it's 10? We don't know. So you basically, the way that this actually works in practice is if it's drifting down, you check it, once a day, maybe twice a day if you're really worried. And as soon as it gets less than 25, you give a blood transfusion. Yeah.
So if this is the opposite to what was expected, where did the question come from to try it?
Yeah, well, the question came from very clever people that just wondered if we were overdoing it, and they postulated that this could be the case. So whilst most of the world would say, gee, that's going a bit low, we'd be a bit worried, they were saying, hang on, we don't know what to do. This is another good example of, we don't know what to do, and there's so many cases like this in neonatology. We don't know what to do, so we do our best guess until we wait for evidence like this, and some clever people thought to do this trial, and they were right.
Yeah. I wonder what their process was in terms of educating parents about the trial to participate.
Well, not being involved, I can't be absolutely sure. But, I mean, I presume the conversation would have gone something like, We don't know what the right number to do transfusions is, but we know in general avoiding transfusions is a good thing if you can. So we're trying to find the right balance, and we've got these two thresholds for giving a transfusion. And there would have been some safety involved there as well. Like, I just want to reiterate that if the babies were bleeding or were really sick, then they would have had a platelet transfusion. But these babies that are, you know, not demanding one, you can wait. Yeah.
Wow, that's amazing.
I just put this slide in as well. This is a similar thing to do with hemoglobin. So this is about avoiding anemia, and this is blood transfusions in the normal sense of the word that people would have heard of giving packed red cell transfusion or whole blood transfusion. And I'm not going to go into the results, but it's a similar theme. Basically, we found that we can wait a bit longer than we used to, and avoiding transfusions is probably a good thing. So that's sort of different blood cells.
Yeah.
All right. I'm going to move on to a bit of breathing stuff now, which is much more sort of in my hitting zone. And this one's going to be about less intubation. So just to remind everyone what the word intubation means, that's the process or the procedure of putting a breathing tube in. So like if you go and have surgery, we might be intubated, or if you're really sick or you're in a car accident or something, you might be intubated. But we need to do that for sick and preterm babies, not uncommonly, to help them with their breathing or if they're not breathing. So this is we need to instrument the airway and put a breathing tube through the vocal cords and into the trachea or the windpipe so that we can provide breathing for the baby. And I'll show you what that looks like in a minute. So when babies are not intubated or on a mechanical ventilator, preterm babies still need support with their breathing. And this is the most common way to do that. This is called continuous positive airway pressure, or CPAP. And any mothers and fathers out there that have had their baby or preterm baby in a neonatal intensive care unit will be very familiar with CPAP, because it's often the most used way of supporting the breathing. But over recent years, we in Melbourne have been involved with quite a lot of studies of this newer and simpler technique of breathing support called nasal high flow, and we're using it more and more in our preterm babies. It hasn't replaced CPAP, and I don't think it ever will unless the interface has changed. But for babies that can manage, this is a good way of supporting the breathing because it's comfortable and easy to use. So we've got a lot of experience now using nasal high flow. So this is Kate Hodgson, who I work with, who is a neonatologist at the Women's Hospital as well, and also at the University of Melbourne. And for her PhD, she had this very clever idea. So in the picture on the left, we've got the silver instrument's called a laryngoscope. So this is the instrument we use to put into a baby's mouth, or if you were having a breathing tube put in, to allow us to identify the vocal cords and then pass a tube through it. But what you can see on this mannequin is that the mannequin's got some nasal high flow prongs in its nose. Because traditionally when we do these intubations, the baby's got no breathing support and no oxygen during the procedure. And you might say, well, why is that? And it's a good question. And so we said, well, hang on, what about if we put some nasal high flow on these babies when we're intubating them? Firstly, would that make the babies more stable and have less oxygen desaturations, or sometimes their heart rate will go low during the procedure, and sometimes they need more and more oxygen during the procedure while we're fiddling around trying to get the breathing tube in? Maybe if we put them on high flow and oxygen, we could keep them much more stable, and maybe that will mean that the person doing the procedure might have more time and the babies will be safer and people might feel a bit less stressed. And particularly so for inexperienced operators. So inexperienced doctors or nurse practitioners who are doing this procedure, who need to learn, who need to be able to do this procedure, but they might be doing it for the first, second or 10th time, which is not very many times. And maybe it would help them just stay calm and the baby stay safer. So we and Kate designed this randomised trial to determine whether that might help. And this is, you know, we're not sort of going to win a Nobel Prize for this. People have been doing this in adult medicine and paediatric medicine, but it just quite hasn't trickled down to neonatology and preterm babies yet. So what we did was we had 250 odd intubation procedures, and the average size of the baby and gestation of the baby was 28 weeks and 900 grams. So these were mainly small babies. And we increased successful intubation without the babies being unstable from 32% up to 50%. So that's a big increase in any trial, and the NNT stands for number needed to treat. That means that if you did this 6 times, you'd have 1 more successful intubation without the baby being unstable. It's a statistical term, but basically it means that you don't have to do this too many times in order to get a benefit. And look at the bottom line there. In inexperienced operators, we increase their success without the baby being unstable to almost 50%, which is still not high enough, and I'll come back to that. But without it, the success rate was 16%. Oh. So we tripled their success rate, and that's really good. But the numbers aren't great, are they? 50% successful intubation without instability is not high enough. We need to be better, and we need to work on other techniques of how we can help with that. I might actually show the video now, Melinda, the one that's for intubation, because one of the techniques we can use is to use a video laryngoscope or an actual video while we're doing this. So if you put that video up now, Melinda. Yeah, this is showing this is the use of a video laryngoscope in a real baby. So this is what we see when we're intubating a baby. And what we're trying to do is identify this little spot where the vocal cords are in the middle. See that black hole right in the middle there? That's the hole between the vocal cords to the airway. And now you'll see this little 2.5 or 3 millimetre tube coming in from the side. And that's the target that we have to hit. And it's not actually that easy to do that every time successfully. And sometimes we have to fiddle around a bit and find the right place, or it goes in the wrong place, or the baby's desaturating or getting sick and we have to stop and try again later. So it's a tricky procedure, one that neonatologists all have to be able to do in an emergency, because it is often an emergency. And this study has shown one way that we can improve the success rates of this and keep the babies safer. So this will change practice, this study. Already many centres around the world have started using nasal high flow for their intubations.
It's amazing.
It's remarkable, because as soon as you said that, I was like, oh, that's a no-brainer. Like, yeah, that makes total sense.
It's an absolute no-brainer. And it's funny because when we did this study, then a whole lot of other people said, well, yeah, of course that makes sense, but we hadn't actually done the study before or proved it. And some of the older neonatologists sort of will tell the story of back in the day, they used to provide a bit of oxygen to the babies or what have you. But now with this new nasal high flow technology, it's a really easy way of doing it. We can give oxygen and some pressure down into the lungs with a high gas flow, and probably that combination of effects of the nasal high flow is really beneficial to the baby. So, so this will become standard practice in many places now, which is really terrific.
Great.
So has it already been implemented from the study?
It certainly has in our centre. So we're doing it whenever we can in our neonatal intensive care unit, and we're getting messages from around the world, from America and Europe, saying, yep, we've implemented this practice. So it will be interesting to see. And Kate's involved in an international database collecting information about intubations from a whole lot of centres, including around America. And that's one of the things they'll start to look at, is how often are they using high flow for their intubations. So we'll get some answers.
Oh, great. Anything that's going to help the baby be stable, such a comfort for parents, you know. There's so much that happens to them that you have to watch and go through. It's just amazing. Well done, Kate.
Yeah, we're making incremental steps to being better. So, so the next study is another breathing one, and it's another Australian study, which is to do with giving surfactant, and I'll explain what that is in a minute. So this X-ray is an X-ray of a preterm baby, and on the left and the right of the screen where the ribs are, they're the lungs with the heart in the middle, and those lungs should be basically black. They should be full of air on this X-rays, and air looks black. And you have to trust me, but they look pretty white, and in fact it's hard to pick out where the heart is in the middle of the screen. Whether you're a doctor or not a doctor, it's hard to pick out where the heart is because the lungs are so white, they're almost blocking out the heart. Now, this is the common breathing problem of preterm babies, called respiratory distress syndrome, or RDS. And this is the result of babies having not enough surfactant in their lungs. And we all have surfactant in our lungs, and surfactant is a lining of the small airways that helps them to stay open. And when you don't have enough surfactant because you're born early, because the surfactant increases later in the pregnancy. So if you don't have enough, your small airways close off and your X-ray looks like this, and you have trouble breathing. And in the bad old days, there was no way to cure that. They just had to support the breathing of babies and hope they got better. But in the last 30 years or so, we've had this stuff on the right of the screens called surfactant available to us. And basically it's a natural surfactant that we can now give to the babies and essentially cure them. And if you ever see a baby receive this, or your own babies receive this, I hope you had the experience of seeing your baby going from needing a lot of oxygen and breathing support to not much oxygen and breathing support, literally in a matter of minutes. It works that fast. Wow. It's injected down into the lungs, it goes all around the lungs, and those airways open up and everything tends to get better quite quickly. So the next question is, how do you get it into the lungs? And having just shown you a study that was about intubation and putting in what we call an endotracheal tube into the airway, that's how you get it into the lungs. You've literally got to squirt it down the breathing tube and down into the baby's lungs. And traditionally, that's always been done the same way you saw in the previous study, where we put in an endotracheal tube, we leave it in, we squirt the surfactant down, and the baby tends to spend a little while on a breathing machine while they recover. But around the world and in Australia, this newer technique has developed. So the question here is, for many preterm babies, instead of putting in the ETT or endotracheal tube, which is the thicker one you see at the bottom of the picture, and the baby being on a mechanical ventilator, could we keep them off the mechanical ventilator, which we know is good for the lungs if they stay off? So, for example, could they be on high flow or CPAP? And could we use this thin catheter, still needs to be inserted in the same way, but pop it in, squirt the surfactant through it and take it out again? And I'm going to show you what that looks like. And this is a video that's widely available, so we're allowed to share it. So could we have a look at that Optimist video, Melinda? Mm-hmm. So here we've got a baby who's breathing for themselves on CPAP. So they've still got that laryngoscope needing to go in, but there's the little thin tube. The baby's still breathing, and you'll see the baby move maybe. And here comes this white surfactant stuff in a syringe. The baby's still breathing and moving, still on CPAP, and they're going to squirt that surfactant slowly in. So that'll go down the tube and directly into the lungs if it's in the right spot. And then simply take that tube out and let the baby keep breathing on their own. And if all of that goes smoothly, it means that the baby's never been on a mechanical ventilator and has just stayed on CPAP. And the theory being that once you've got the surfactant in, it cures the lungs and you don't need to escalate the respiratory support and spend time on a ventilator and all that. So that's what it looks like. Probably should have warned people before showing that, shouldn't I? But never mind. That's a widely available video on YouTube. If you can go back to the slides, please, Melinda. So that's the technique that Professor Dargaville, a friend of mine in Hobart, has developed. And he did this Optimist trial. And this is what it showed. This was a study that was all over the world in many, many centres, and 485 extremely preterm babies. And there was a reduction in a very important outcome called BPD, or bronchopulmonary dysplasia. That's the chronic lung disease that we talk about of extremely preterm babies. And this trial showed a trend, or a decent reduction in that, which not many studies have shown. And it also showed that the babies less often needed to go on and be on a mechanical ventilator. So this technique meant that we were able to avoid having to then put in an endotracheal tube and go on a ventilator in about half the babies. You can see that the rate of needing to be intubated was about half in the babies in the thin catheter group compared to the babies that just went onto a ventilator and were treated in the standard way. And that's all well and good, but literally last week or the week before, they published their 2-year outcomes from that study. There was about 450 babies included in this follow-up. And whilst there wasn't any difference in things like mortality or growth and development, there was a reduction in a lot of the breathing issues that parents tell us are important. So it's all very well for the neonatologist to worry about something called BPD, which is a diagnosis that most parents wouldn't have even heard of. But this is really important stuff. The babies that had that thin catheter technique had less often been hospitalised for breathing difficulties. Their parents said they were wheezy less often. There was less diagnosis of asthma by a doctor and less asthma medication use. So just that one procedure of putting in the surfactant with the thin catheter technique and more often staying off the ventilator has resulted in these benefits 2 years later. And it's a really good reminder that the things we do in the first seconds, minutes, hours and days of life for preterm babies have lasting effects, in this case to 2 years, but who knows, maybe even into adulthood. So that's really interesting.
So it's not a reduction in the amount of surfactant that's given to the baby, it's just the way it's given, just the process.
So these babies all need surfactant. So these are all babies that must have surfactant. So they're having trouble breathing, they're needing oxygen, they all need surfactant. And this study compared whether giving the surfactant with that thin tube staying on CPAP was better than putting in a thicker endotracheal tube and going on a mechanical ventilator, which is the way we've always done it. And you can see that the outcome, just staying off the ventilator for, in some cases, a matter of only hours or days, has these lasting effects. So again, this is not the only group that's looked at this. This has been something that's been going on quite a lot in Europe, for example, but this is the biggest study of this and will certainly change practice.
So it's so nice to. Oh, sorry, no, I was just going to say. I was just going to say it's so nice to see that 2-year follow-up. Like I feel like that's just awesome that there's that consideration of, you know, not just in the NICU setting itself, but, you know, how does it impact families and the baby later on, you know, because that's, you know.
Yeah, and it you know, it's really important that in all of our clinical trials we try and follow up the babies. You know, certainly if it's something really important like this, you know, it's not enough now just to show a brief benefit in the neonatal period. What families and doctors really want to know is, well, does that result in some important lasting effect? And there are many examples of something being effective in the short term but not in the long term, or even being dangerous. Or vice versa. You know, you might not see such an effect early on, but you might see more of an effect later on. And so this is another reason why doing neonatal clinical trials is so very difficult, is that we have to get lots of little babies. It takes a long time to prove things, and then we have to follow them up for as long as we possibly can. So that's why some of these trials take 5 or even 10 years to get important results. So it's hard work, but it's worth it when you get results like this team did.
Absolutely, yeah. Sorry, Mel, what were you going to say?
No, well, I agree, because these are the things that make a difference to families. You know, when their child's growing up and the things that they live with, watching them with breathing difficulties is awful. So it's amazing. I was just going to ask, how long will this one take to get into practice? Like, is this starting to change practice already?
Absolutely, yeah. So there were some European centres were already doing this as standard of care even before this trial was complete, or even before it was started. But this will convince a lot of people who weren't already doing this. And there are some parts of the world, even in high income places, where they've been not sure about whether they should do this. I think this will change their mind in a lot of cases. In Melbourne, Australia, we took part in this study with our colleagues in Hobart, and we've immediately instituted this in our centres. So this is standard now.
And is training part of it, like having to retrain everyone, or is it something that they can pretty much like uptake, or is it like a massive training?
It's still a skill that needs to be learned. It's a slightly different technique. The babies are breathing and they're on CPAP compared to usually a more controlled environment, and sometimes they're sedated with the other techniques. So yeah, this is not super easy, and it's something that everyone has to learn to do now, but that's fine, because if it improves outcomes, then that's what we're going to do.
Yeah, absolutely. Wow. Every single one of them goosebumps.
Well, and another good friend of mine, Callum Roberts at Monash, has seen this and gone with this new idea that we got from some of our friends in Scotland. Joyce O'Shea used to work with us, and she's been doing this over in Scotland. Well, the theory here of the Surf's Up trial, great name, isn't it? The theory here is, hang on, that's all well and good. We should use the thin catheter, but you still have to be able to learn that procedure this is directly related to what you just said, Melinda. You've still got to be able to use that laryngoscope, the silver metal thing, and you've got to, get the tube in the right spot, and maybe it's not that comfortable for the babies, and sometimes they don't tolerate it well. What about if we use this other airway device? This is called a supraglottic airway or a laryngeal mask. And many of you will have had one of these in your mouth, even if you don't know it, because this is a common way if you're having a surgical procedure that the anaesthetist will manage your airway while you're under an anaesthetic. And this thing just slides in. So there's no sort of metal device. You just literally put it in the mouth, and if you push it in, it goes in the right place. And it basically keeps your airway open, and you're able to provide oxygen and breathing support down this tube. So this is a common device used in paediatrics and adult anaesthetics, and being used more and more in neonatology, even in the delivery room. But no one's ever systematically studied whether, well, hang on, if this thing just shoves in your mouth and you don't even need to know really how to do it, it's so easy. It really is easy. Well, could we squirt surfactant down it, and would it go in the right place, and would it have the same effect? And the answer is maybe. So this is a trial comparing the previous technique I just showed you with the thin catheter that's now standard practice to simply putting in a supraglottic airway or laryngeal mask device and squirting the surfactant down and seeing if that works just as well. This would be really important in a few scenarios if it works. Now, firstly, the first one thing to say is that these devices aren't, they don't go as low in size as we would like. So we can't do this in 500 gram babies or 700 gram babies, but we can do this in 1.5 or 2 kilo babies who need surfactant. So that's the first thing to say about it. But there are many babies around Australia, as an example, who have preterm babies born in peripheral hospitals or non-tertiary hospitals with special care nurseries where most preterm babies are born, who then develop respiratory distress syndrome and need surfactant treatment. And at the moment, the only way for them to get that is for our neonatal transport teams to leave the city, go out to the country or go out to the peripheral hospital, metropolitan centre, wherever it is, intubate the baby, give them surfactant, bring them back to the metropolitan centre where they might spend a day or two and then go back again. And if we could avoid that by having a simpler technique that paediatricians, nurse practitioners, residents, whatever, could learn in those peripheral centres, and it worked most of the time, even if it wasn't all the time, just most of the time, we could avoid that huge kerfuffle and separation of the family and the baby of needing to bring the baby to a tertiary centre in a city somewhere to have their surfactant or to be managed after their surfactant. So that's why that's so important. So we've just started this, so we don't know if it's going to work, but hope so. Melinda?
Sorry, I muted myself. And reduce the time that they get surfactant.
Yeah, that's right. In many cases, because if whoever's looking after the baby, could be anyone, I mean, potentially midwives, nursing staff, junior doctors, are able to do this technique, then it could be done when it needs to be done. And then they could sort of just give the transport team a call and say, well, I've done this and it's going well, we'll keep the baby and see what happens. That would be amazing.
I wanted to ask one question when you said that this probably happens when, as an adult, you go under for surgery, you have the tube put down. But when that happens, we've had anaesthetic or, like these babies don't get painkillers, do they? Like there's no anaesthetic most of the time when they go through any of these processes?
It's a controversial topic you've touched on, and I'll try and summarise it. So for the old school way of giving surfactant down the endotracheal tube, the thicker tube, yes, more often than not, those babies, nearly always, those babies receive painkillers, sedation, and sometimes even muscle relaxants. So sometimes they're even paralysed like a full anaesthetic. And in fact, that's pretty standard practice for us because we don't think that having that bigger tube down and going onto a ventilator is very comfortable. However, for the thin tube technique that I showed you in the previous study, that's really controversial because the benefit of that technique is that babies keep breathing. And if you give them too much medication or you give them a full anaesthetic, it almost defeats the purpose because then they're not breathing and then they need to go on a mechanical ventilator. It's controversial. We always give, to reassure families out there, we always at least do something. We wrap the baby, we give them some sucrose or some breast milk to keep them comfortable, and we are as quick as we can be. And in many places around the world, they say that's not enough. So there are many places giving small doses of drugs like morphine to be able to keep the babies happy and without pain during those procedures. And they try and give a small enough amount that it doesn't stop the baby breathing. but it's not well studied. We don't know for sure what the best thing to do is. For this technique here, it does not require the insertion of that metal instrument called a laryngoscope. And we think this is more comfortable probably, although can't speak for the baby. So we're thinking a technique of just some wrapping and sucrose might be enough for this. Keep the baby's breathing, pop in the supraglottic airway or laryngeal mask, give the surfactant and take it out. And if it's a matter of minutes, that might be enough. But it is a little controversial because babies feel pain. No one denies that anymore. And for many, they feel that these techniques might need a bit more pain relief than most babies are currently getting. Something else that we're looking at.
Yeah, we actually did an episode with Denise Harrison on Beast Week to babies and the 3 ways to help them through pain management. And you've just mentioned a couple there, so it's amazing.
I'm sure she mentioned that for things like blood tests, we know that breastfeeding or giving some sucrose or breast milk it seems to be very good analgesia, good pain relief. The question is whether it's good enough for procedures like this, and it's quite controversial. You know, doctors argue over this at conferences actually because they say, well, I would never do this to a baby, just like I wouldn't want it done to me. And then others say, but we see that the babies seem comfortable and it's more successful without giving lots of drugs. So it's a bit controversial, that one.
Yeah, absolutely.
All right, last one. So that was Peter Darga's Optimist trial, and we're going to change tack quite a lot here. We're going to talk about something called neonatal abstinence syndrome, or NAS. So for those of you who've never heard about this condition, and that will be most of you, it's actually not uncommon, as you might expect, knowing how society works and some of the issues in society, that we're looking after babies born to mothers who are on drugs. And what type of drugs are most common varies over time. So, over recent decades, that's been heroin and opioid-based drugs like that. And so some mums will be on heroin. Some mums will be receiving treatment for their heroin addiction and be on drugs like methadone to try and help them with that. But what we know is that that drug always crosses the placenta and gets to the baby. And that's true of other drugs like alcohol, etc., and medications as well, which is why we have to be so careful. And if a baby's been exposed to drugs like heroin or methadone for a long time while they're in utero, while they're still growing in the uterus, and then they're born, they withdraw from drugs just like anyone else withdraws from drugs. I might just point out at this moment that we wouldn't say a baby is addicted to drugs. The baby's not addicted to drugs. Their mother might be addicted to drugs. This baby's not addicted, but they are withdrawing. And we need to help them get through that period of withdrawal, because if we don't, they really suffer. So they suffer, irritability, poor feeding, diarrhea, rashes. It's really, 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 really difficult, and they require a whole lot of dedicated nursing. Now, I mentioned opioids and heroin. Things change over time, and at the moment, one of the big epidemics overseas and in Australia is amphetamines. So drugs like ice are more common, but still we have this issue with heroin and opioid addiction in mums. So this is a picture just of a crying baby. It's not a real baby with neonatal abstinence syndrome, but it does depict well what our nursing staff are dealing with in neonatal units around Australia and around the world really commonly, much more commonly than we'd like. And the standard way of looking after these babies is to do a score called a Finnegan score. And this is where there's basically this long checklist of symptoms that babies get if they're withdrawing from drugs like morphine or heroin. And it scores things like their facial expression, how well they settle down, whether they're having any physical symptoms, what's their heart rate doing. And the nurse will score that. And if it adds up to a certain score, a certain threshold, that means the baby needs treatment. And when I say treatment, unfortunately, what that means is to give morphine. So if you're withdrawing from morphine, the only thing that makes you feel better is morphine. Now, whilst that might sound shocking, we're not sort of trying to make these babies addicted to drugs. We're in fact trying to wean them off safely. And without treatment with what they're withdrawing from, they won't thrive and they can get very sick. Worst case scenario, they can have seizures and be really, really unwell. So we give them low doses of morphine and we gradually wean that off over a few weeks. And just like an adult withdrawing from drugs, that's successful in doing that. So we try not to treat, but if we have to treat, we do, and then we wean the babies off carefully. This is just a graph from the US showing how big a problem this is, and it's a massive problem. Like, we look after a lot of babies like this, and we usually have in our units a couple of babies at a time. But in the US, there's whole nurseries full of babies with this problem, and it's a real epidemic, and it's a real impact on society, actually. This is a study, an Australian study from a couple of years ago by Julie Uwe and colleagues from New South Wales. And it's just to point out that this is not a benign condition. So for babies who had neonatal abstinence syndrome, who were withdrawing from their mother's drug use, this showed how they scored on intelligence scoring, basically. In grade 3, you can see that you don't need to know what the scores mean, but 359, much lower than babies that weren't exposed. And by year 7 or grade 7, they were scoring lower than other children in grade 5. So this has a lifelong, or at least a childhood impact, being exposed to drugs whilst you're in utero. And, we could talk about other things, but the alcohol story is not dissimilar, and another problem that we're dealing with in our society as well. So this recently published and very interesting study from the US, I think it was in about 25 or 26 neonatal units in the US, looked at a new way of approaching these babies, or maybe an enhanced way of approaching these babies. So what they did was they taught all of the staff, particularly the nursing staff, this approach called Eat, Sleep and Console. And basically this approach is one that involves intensive nursing care, looking for cues of how to respond to the baby's distress, carefully looking for cues that the baby wants to feed, supporting these children in a quiet environment, which is tricky sometimes in a busy neonatal unit, swaddling, rocking, consoling, and the use of kangaroo care. There it is again. Whenever the mother's available or another family member, trying to get them skin to skin. And basically they showed by teaching these techniques, compared to the usual way of just using the scoring system that I referred to before, that they were able to basically halve the time that it took to get the babies home or to have them ready to go home. So 8 versus 15 days, that's a huge change. It might not seem like much, but reducing the time a baby needs to be in hospital by a week, not only is it good for the babies and the mothers and getting the families together and getting things back on track, it's really important at a societal and a financial and a health system level to halve the time of an admission. And these babies sometimes stay in hospital for weeks. So this is a really interesting outcome. What do you think about that one, guys?
Have they done long-term on that one in terms of, how you were showing the outcomes for primary school? By doing this process and reducing their hospital stays, has it got a positive effect?
Yeah, we don't know yet because it's just published. So they've just published that trial, but you're absolutely right. I hope they are. It's probably written in the paper, but I hope they are planning on following these children through, because you're right. You want to be able to show an immediate effect in the newborn period, and they have. And now it would be nice if they could show that the babies did better, or even at least as well, because even if they did just as well, they've still spent a week less in hospital, and that's a hugely beneficial thing. So I hope they do that.
It's remarkable. And it's lovely to see.
I'm kind of sensing a theme of, those interventions are quite natural interventions, to look at the baby's cues and to swaddle them and, not time feeds, but rather, let them tell you when they're ready for feeds, and kangaroo care. And it's amazing, isn't it?
Cord clamping and keeping the doctors away from the babies. Yeah, there is a bit of a theme there, isn't there? And that's honestly, it's been one of the biggest changes in neonatal intensive care, even in my short time in this profession, is doing less We're just learning more and more that we can do less. Now, I don't want you to think for a moment that that means we can do nothing, because it doesn't. You know, it takes a lot of skill, teamwork and intensive care to keep many of these really tiny or really sick babies alive. So just put that out there. But there are many cases where we can do less, or less invasive procedures, or less painful procedures, or keep mothers and children together where in the past they've been separated.
Yeah. And Brett, just curious, because in a lot of the examples that you gave, you kind of mentioned, oh, and this is already into practice, or we're already doing this, and, which is great to hear. There's like an immediate response. But is that normal in a lot of kind of neonatal research, like that it happens that quickly?
And it's not only neonatal, it's other research too. You wouldn't believe it. You know, people spend their entire careers doing these studies, and then it takes a long time for the results to be translated into practice. I think there are some papers out there suggesting it takes on average 7 years for people to have good uptake of new results. Now, some of these studies are so influential in our relatively small field. You know, neonatology is a very specialised field and everybody knows each other. And so what happens is people like Peter Dargaville he's over in Europe right now. He's travelling around telling people the results of his Optimus trial and the improved 2-year outcomes. And then there's almost like peer pressure. Come on, if you're not doing this, you need to get on and do it. We've not only shown early beneficial outcomes, now we're showing later beneficial outcomes. And if you're not doing it, you're behind the 8 ball. So we're getting better at it. And then people will produce guidelines where they'll say, you know, the official stance of American Pediatric Association or whatever is that now we do this procedure, and that always moves people along as well.
Great. All right. Oh, that's wonderful.
Australia's one of the best at this, I must say. Australia's not only great at producing the research, we're great at implementing it into practice compared to some other countries.
Why is that? Because it's smaller, or just?
I don't really know why. Maybe because we're smaller and more insular, and we're involved in a lot of the research that we've been better at. This is a long history of this phenomenon, you know, and New Zealand as well. Australia and New Zealand's worked together amazingly over the decades, looking after preterm babies. One of the best examples is antenatal steroids, which hopefully you've all heard of. That's the injection of a steroid medicine into the mum if she's expected to have a premature baby. You got that, Nat? Yeah. And Melinda, did you get that? You know, that concept was discovered by some New Zealand scientists, and it took decades for that to be translated into practice around the world, even though it increases survival. Whereas Australia and New Zealand were much quicker on the uptake, thankfully.
Yeah. That's wonderful. It must
what would be your... No, you go.
Right. No, it's really exciting when, you know, there's this kind of like, for me, like there's this, you know, there is all this work that's been done and it's published and it's like, yes, this works. And then people are like, you know, there is pockets of people responding to it immediately. And it just means, you know, there's babies, you know, there's families already seeing and getting to, you know, in Australia that are benefiting from this already. It's just, it's cool.
And unfortunately, the converse is sometimes true as well. And it's one of my bugbears, you know. There's so much that we do every day in a neonatal unit that is not based on really good evidence and big trials. And yet when there is really good evidence or big trials, sometimes people are slow to accept it, or they'll pick holes in the trials. And, you know, no trial is perfect. That's the other thing. It's really hard to do clinical trials and make them perfect. But I personally feel it's really important that we act on really good evidence and make sure that we're all doing it.
But do these trials typically have like afterwards, like some kind of implementation team or something that kind of goes about helping or kind of supporting people?
Yeah, that's becoming much more common. It's becoming a standard practice now that it's not enough just to do a trial. You've got to have a way of implementing that as best you can. So the usual things of presenting at conferences and publishing the paper aren't enough anymore. Really, there are people who are specialists, believe it or not, now in translating evidence into practice and how that's best done. And look, things like presenting these papers on your podcast, it all helps, right? So yeah, hopefully we'll get better at that.
Well, that kind of leads into my question. What would be like for parents? What's your advice, or what's your takeaway for parents?
Yeah, well, there were some of the studies I presented today. You know, some of them are intensive care respiratory studies where it's hard to sort of, you know, tell your doctor what to do necessarily, because there are nuances and there are some babies that these techniques can't be used in. But things like delayed cord clamping, skin to skin or kangaroo mother care, they're things that people need to understand are possible. And we see many mums and dads and families that are scared of that concept or don't even believe it's a thing. What do you mean? What do you mean I can hold my 1 kilo baby? Really? I'm too worried about it. But, you know, it's really important for us to offer it and make sure it happens as much as we can. Now, we're not going to force anyone to do anything, but we know it's good for the babies and we know it's good for the mums and dads as well. Honestly, sorry, just to divert for a second, but there's no better sight than being on the ward round in the intensive care unit and seeing a mum or a mum and a dad with twins or what have you, both doing skin to scare, you know, as the hairy-chested dad on the ward round. It's just awesome. And we love it. So it's our job to make sure that it's offered, but it's really important to spread the word so parents in this situation understand that usually that's possible. Not always. The sickest babies or the tiniest babies, sometimes it's not appropriate, but most of the time it is. And same for delayed cord clamping. It should be practiced all around Australia, so you shouldn't have to ask, but you can. You can.
Absolutely. No, that's amazing. And I think even, like I was saying, I was getting goosebumps just listening to all the outcomes and how important they are and how significant they are. I think it's amazing, but it's also encouraging for families who find themselves in the NICU and in that situation about the importance of participating, like being, you know, having some confidence about saying yes to trials or wanting to be educated and to learn more. And find out what kind of trials are happening within the NICUs and if your baby is able to participate and saying yes to trials. I think it's amazing.
Yeah, thanks for the opportunity to mention this, Melinda. You've hit the nail on the head there. None of these trials, I've just presented 5 trials that had accumulated thousands of babies enrolled and mothers. And every single one of those babies or mothers enrolled was enrolled with a consent process where they said yes. They heard about the trial and they said yes. And without those yeses, none of this happens. And we still keep doing our bad old practices without even knowing we're doing bad practices. We have to fix this. We have to be better. And now that we're looking after sicker and smaller, tiny preterm babies born as little as 23 or 22 weeks of gestation and 500 or 400 grams, there is a real lack of evidence for those babies. And we must know what's best, because if we don't find out, we may be doing harmful things. And you know, some families worry. They say, I don't want my baby experimented on. But the more we talk about this, the more families will understand that we're not experimenting in that sense of the word. We're trying to work out which of 2 ways of doing something, or sometimes 3 or 4 ways of doing something, is the best. And from that moment forward, once that's determined, all babies and families will receive the best treatment, and no babies and families, or far fewer, will receive the worst treatment.
Couldn't say that better. That's amazing. Well, thank you so much for joining us and sharing your top 5 recent neonatology papers. I know that we're definitely going to have you on a whole lot of more episodes because we enjoy talking to you and there's so much to learn from you.
Thanks, Melinda. Thanks, Nat. And hi to everyone out there. And look forward to seeing you again soon.
Lovely. Thank you, Brett. See you.
Bye.
That's a wrap on another episode of the NICU Live Network. Thanks for joining us today. To stay connected, please make sure you're following us on social media.
And if you found value in this episode, please share, like, or comment.
We'll see you on the next episode.